Hey, welcome everybody. My name's Nick Swire. I'm introducing our speaker at today's webinar. Our speaker is Alice Havard, and Alice is a Senior Research Fellow in the Centre for Big Data Research in Health at the University of New South Wales. Alice is supported by New South Wales Health Early Mid-Career Fellowship, and her research uses linked administrative data to improve our understanding of how medicines are used at population level, their safety and effectiveness in the real world setting. And Alice is going to talk to us today, as you can see, about the use of smoking cessation pharmacotherapies in pregnancy, which has always been a very controversial area and where information about safety and effectiveness is certainly much needed. So I'll hand over to Alice. I see we've got about 14 people online, which is great. Feel free to post questions as we go along, and we'll get to those after Alice has finished the presentation, which I understand is going to be about half an hour, and then we'll have plenty of time for discussion and questions. So I'll hand over to Alice.
Thanks, Nick, and thanks everyone for joining today and for your interest in hearing about this research on the use and effects of smoking cessation pharmacotherapies during pregnancy. So this research was funded through an NHMRC project grant, and it was a collaboration between investigators at 4 Australian universities and a colleague from the University of Iceland. So I'm sure this audience is no doubt aware that smoking during pregnancy is a leading cause of adverse birth outcomes. Smoking increases the risk of pregnancy complications, such as placental abruption and placenta previa. It also increases the risk of poor neonatal outcomes, such as growth restriction, preterm birth, stillbirth, and congenital anomalies. And the harms also extend into childhood. So smoking during pregnancy is associated with an increased risk of sudden infant death and adverse neurodevelopmental effects in children, like an increased risk of ADHD. And although the prevalence of smoking in pregnancy in Australia is declining, still around 1 in 10 pregnant women in Australia smoke. And the risk of adverse outcomes can be reduced if mothers quit smoking, especially if this is achieved within the first 20 weeks of gestation. And psychosocial interventions like counselling, feedback or peer support are recommended as first-line options for women who smoke during pregnancy. But the evidence regarding the effectiveness of these interventions is inconsistent. And under current practice, less than 25% of women who smoke early in pregnancy succeed with quitting by late pregnancy, so that indicating a need to identify treatments that are more effective for pregnant women. And this brings us to smoking cessation pharmacotherapies. So in the general population, pharmacotherapies are one of the most effective smoking cessation strategies available. And although evidence from the general population of smokers doesn't necessarily generalise to pregnant women, because these medicines have altered pharmacokinetics and pharmacodynamics during pregnancy, this evidence does suggest it's worth exploring whether smoking cessation pharmacotherapies might be a good option for women smoking during pregnancy. There are 3 pharmaceutical products registered for use as smoking cessation aids in Australia and most other developed countries. These include bupropion, which is sold under the brand name Zyban, varenicline, which is sold under the brand name Chantix, and nicotine replacement therapy, of which there are multiple brands. In Australia, all 3 are subsidised through the PBS when a prescription is obtained. Bupropion's been subsidised since 2001. And varenicline since 2008. Various forms of NRT have been available over the counter since 1997, but in 2008, the patch form of NRT became available for Aboriginal patients, and the subsidy for NRT patches was extended to the general population in 2011. And in 2019, NRT gum and lozenges were added to the PBS schedule, but the study that I'm describing today doesn't cover this recent development. So when considering whether these medicines might be a good option for women smoking during pregnancy, we need to think about both their effectiveness and safety in pregnancy. Prior evidence on both these things was pretty limited. For bupropion, there'd only been small studies of pregnancy outcomes, and a couple of observational studies, but these were limited in that they were unable to distinguish between bupropion used for smoking cessation and bupropion used for depression, because in some countries bupropion is registered as an antidepressant. We can avoid that problem in Australian studies because smoking cessation is the only registered indication for bupropion here. For varenicline, for a long time, the only evidence came from small, uncontrolled studies. But late last year, an observational study based on data from Denmark and Sweden was published. And this study found that the risk of adverse birth outcomes was no higher among women using varenicline during pregnancy compared to women who smoked during pregnancy and didn't receive varenicline. Unfortunately, many of the estimates from this study were imprecise because of the relatively small sample size, so it's not strong enough evidence to rule out that varenicline could potentially be harmful. And the effectiveness of varenicline during pregnancy hasn't been measured at all. Now, there's been much more investigation of the outcomes of NRT use during pregnancy, but this still hasn't resulted in any definitive evidence. The latest Cochrane review on the topic concluded that there's insufficient evidence to determine whether NRT use is associated with an increased risk of adverse birth outcomes. And it also concluded that there is some evidence that NRT can increase quitting during pregnancy, but the evidence is of low certainty. And there have been observational studies on NRT use during pregnancy, but they've returned inconsistent findings. So given this lack of clear evidence, clinical guidelines in Australia advise against the use of varenicline and bupropion during pregnancy. And most clinical practice guidelines state that NRT can be used during pregnancy if the expected benefits outweigh the risk, and if prior attempts with NRT have been unsuccessful. Prior attempts without NRT have been unsuccessful. Now, although the evidence regarding the effectiveness and safety of NRT is still not clear, there's general support for the use of NRT during pregnancy based on the assumption that it's unlikely to be more harmful than smoking itself during pregnancy. So with that background in mind, we set out to measure 3 things in relation to these medicines. Our first aim relates to their utilisation. Specifically, we sought to examine the extent to which bupropion, varenicline and prescription NRT patches are used during pregnancy in Australia. Our second aim was to measure their comparative effectiveness, that is, whether the likelihood of quitting during pregnancy differed according to the type of pharmacotherapy used. And third, we examined the safety of these medicines in pregnancy. Specifically, we sought to determine whether any of the pharmacotherapies increased the risk of adverse birth outcomes compared to women who smoke during pregnancy but didn't receive a pharmacotherapy. Now, I'll refer to these women throughout as untreated smokers, but I do note that that's not strictly an accurate description because they may well have received some other form of treatment. We addressed these aims using linked, routinely collected data. So we obtained data for all pregnancies resulting in a birth in New South Wales or Western Australia in the 10 years between 2003 and 2012. Records of these pregnancies were obtained from the perinatal data collections in those states, and where perinatal data contained detailed information about the pregnancy, the delivery, and the neonate's health collected by the midwives at the time of birth. These perinatal records were linked to records from our National Pharmaceutical Dispensing Database, so the Pharmaceutical Benefit Scheme data. And this database includes a record of every medicine dispensed that the Australian government paid a subsidy for. So it includes records of all dispensings of varenicline and bupropion and prescription NRT. And we also linked records of hospital admissions, emergency department presentations and deaths for both the mothers and children, and records of congenital anomalies for children born in New South Wales. So how did we use these data to address our first aim, which was to measure the utilisation of smoking cessation pharmacotherapies in pregnancy? Well, the first step was to identify pregnancies during which the mother smoked. So this was determined from smoking status in the perinatal record, along with smoking diagnoses in the hospital admission record associated with the delivery. Then we use the dates of dispensing and the quantity dispensed of the pharmacotherapy from the PBS data to identify when these women had one of the smoking cessation pharmacotherapies in their possession. And when the dates of possession overlapped with the dates of pregnancy, we defined this as use of the pharmacotherapy during pregnancy. So this means that we've counted women who received the pharmacotherapy while pregnant as using it, and also women who received the pharmacotherapy before pregnancy, as long as that dispensing was close enough to the date of conception to assume that she would still be making her way through the amount supplied. Now, this approach resulted in a situation like this, where there was a lot of pharmacotherapy use among pregnant women who weren't recorded as smokers. So that just under half of the pharmacotherapy use was among women who weren't recorded as smokers. And now, like, some of this might be legitimate, with women already having achieved abstinence and just finishing up the course. But we were also aware that there's an underreporting of smoking during pregnancy. So we suspect that many of the women using pharmacotherapy were actually smoking in pregnancy but weren't recorded as such. And not addressing this would have led to an underestimate in pharmacotherapy use during pregnancy. So we used various details about the pharmacotherapy supplied to reclassify some of these women as smoking during pregnancy and obtain more realistic estimates of utilisation. I won't go into the details about how we reclassified women. If you're interested in learning more about it, this process is described in the PLOS One article cited at the bottom of this slide. So now to what we found. So you can see here that bupropion is used by very few women during pregnancy. So only 0.2% of women who smoked during pregnancy used bupropion since the beginning of our study. For varenicline, since it was introduced in 2008, it was used by 1.8% of pregnant smokers. And then prescription NRT patches. Since the subsidy was extended to the general population in 2011, from that point onwards, prescription NRT patches were used by 1.7% of women smoking during pregnancy. Now, I think the low prevalence of bupropion is not that surprising. It doesn't seem to be that favoured anymore. The prevalence of NRT use might seem quite low compared to the prevalence of varenicline use and also the estimates from other countries about how often it's used during pregnancy. But it's important to remember here that we've only been able to measure subsidised use. So where NRT is also available over the counter or for free through some specific programs and through remote area Aboriginal health services. The prevalence of varenicline use, this might come as quite a surprise given that it's not recommended by guidelines to be used during pregnancy. But it could be that this is because we have included women who commence the pharmacotherapy before pregnancy and women who commence early in pregnancy, and at this point they may not yet be aware that they are pregnant. So I'll just illustrate that a little bit further here. So this diagram shows when each pack was dispensed in relation to the date of conception. And I think it reinforces that hypothesis that shows that varenicline was often commenced before conception and almost always in the first trimester. So women may not have known they were pregnant at the time they started the course. The pattern for NRT is quite different. Its use wasn't clustered around preconception and early pregnancy, with many women commencing NRT later in pregnancy when they're more likely to be aware that they were pregnant. Okay, let's move on to the effectiveness of these pharmacotherapies in pregnancy. So recall that our aim was to compare different pharmacotherapies in terms of their capacity to support smoking cessation. But as our utilisation analysis revealed, there's very little use of bupropion during pregnancy, so we focused this comparison on varenicline and NRT. We addressed this aim with an observational study, noting that randomised control trials involving the administration of varenicline or bupropion to pregnant women are unlikely to be considered ethical, while the safety of these medicines is unknown. And although there have been trials of NRT in pregnancy because of the assumption that it's safer relative to smoking, trials have struggled to obtain samples of sufficient size to produce clear evidence. So in these circumstances, observational studies based on routinely collected data are the only way to obtain large enough samples to provide robust evidence. Now, the major concern with observational research is that women are not randomised into treatment groups, so any observed effects could be due to confounding rather than the treatment itself. And being aware of this possibility, we were really careful to gather information on potential confounders from the multiple data sources that we had available, and we used sophisticated methods to evenly distribute these factors between our treatment groups. And I'll give you a bit more information on that once I've described the study population and measures. So to study effectiveness, we selected all pregnancies conceived from the 1st of January 2011 and those that resulted in delivery before the end of 2012. And then, using the information on smoking that's included in the perinatal record for all births, we narrowed the cohort down to women documented as smoking during the first 20 weeks of pregnancy. And within this group, we then examined who was dispensed varenicline or NRT and selected those women who commenced their course of varenicline varenicline during the first 19 weeks of pregnancy and NRT during the first 18 weeks of pregnancy. And I'll explain in the next slide why we used 19 and 18 weeks there. And based on these criteria, our study included 106 women dispensed varenicline in the first half of pregnancy and 135 dispensed NRT. The outcome in this study of effectiveness was smoking cessation, which we measured using the information on quantity smoked after the 20th week of pregnancy, which is available in perinatal records. So women who were recorded as smoking 0 cigarettes per day after the 20th week of pregnancy were defined as having quit. Now that we understand how the outcome was measured, we can return to that decision that I mentioned about restricting to women commencing a course of NRT up until the end of week 18 and those commencing varenicline up until end of week 19. So we did that to allow for scenarios in which women do not attempt abstinence on their first day of therapy. So instead, they initiate the medicine sometime before their predetermined quit date. And based on guidance in the literature, we assumed this would be 2 weeks for NRT and 1 week for varenicline. So this means that women in our study who commence NRT at the latest possible point that we've allowed have 2 weeks of treatment before their outcome is measured. And for varenicline users, this is 1 week. And to confounding. So as I mentioned earlier, because this isn't a randomised study, we had to be careful about avoiding confounding. One advantage that we had is that we were comparing women using one smoking cessation pharmacotherapy with women using another. So we were already focusing on women who would be fairly similar in their interest in quitting and perhaps their level of nicotine dependence. But there could still be differences in which women chose varenicline over NRT or vice versa. So we measured a range of potentially important factors using the various data sources that we had available. And then we used a weighting method to make sure that these factors were evenly distributed in our varenicline and NRT treatment groups. So what did we find? Well, we found that varenicline was more effective than NRT patches. A higher proportion of varenicline users had stopped smoking by the second half of pregnancy. So specifically 12%. And when we describe that in terms of risk, varenicline users were 2.2 times more likely to quit smoking than NRT users. Now, we need to take the magnitude of these effects with a grain of salt, because you might see there that the confidence intervals are quite wide, but the direction of the effect does suggest that varenicline has superior effectiveness to NRT patches during pregnancy. So this just gives us more reason to investigate the safety of varenicline during pregnancy. So I will move on to those analyses now. So let's start with who we included in our study of safety. The first thing to note is that users of each pharmacotherapy were compared against women who smoked but didn't receive a pharmacotherapy, who are referred to as untreated smokers. But the untreated smokers were from a different calendar period, depending on when the pharmacotherapy became available. So if we take varenicline as an example, it's been available since 2008. So we compared varenicline users against untreated smokers who also had pregnancies from 2008 onwards, just to avoid any confounding by calendar time. After defining the study period for each pharmacotherapy, we identified which pregnancies were eligible to be included in the comparison based on their conception date falling within the study period. We then determined which women were smoking during pregnancy and then identified those using the pharmacotherapy. So as with our measurement of utilisation, we considered a pregnancy exposed to pharmacotherapy if the dates of medicine possession overlapped with the dates of pregnancy. So again, a pregnancy was considered exposed if there was one or more dispensing of the therapy during gestation, or dispensings before conception were sufficient to last into the pregnancy. Safety was measured in terms of various birth outcomes, including preterm birth, small for gestational age, placental abruption, and there are a list of 10 of them here. This is a typical set of endpoints examined in studies of medicine safety during pregnancy. They're chosen because there are risks to the mother or to the neonate that could theoretically arise from any chemical exposure during pregnancy or gestation. The primary outcome was a composite of these 10 adverse birth outcomes. And in addition, we looked at the risk of congenital anomalies in the infant. But these are quite rare events, and our capacity to do this robustly was limited by our population size. So just as we did when examining effectiveness, we went to a lot of effort to make sure that potentially confounding factors were balanced in our comparison groups. We did that with propensity score matching, which gives each woman a summary score on all potential confounders, and then only includes women in the pharmacotherapy group and the comparison group if they have similar scores. So for every woman in the pharmacotherapy group, we selected 10 women with similar propensity scores to include in the comparison group. We based this approach on a similar set of potentially confounding factors as used in the effectiveness analysis. And we analysed the data with survival analysis, as this takes the timing of exposure to the pharmacotherapy into account. So after propensity score matching, we had 232 bupropion users. With this number, we couldn't examine 4 of the planned outcomes because they occurred too infrequently. But for the remaining outcomes, so there was no significant relationship observed between bupropion use and the primary outcome or any of the secondary outcomes. And similarly for NRT, so we had 328 pregnancies exposed to NRT patches, and again, there were no significant relationships observed between NRT exposure and the primary outcome. 2 of the secondary outcomes couldn't be modelled because they were too infrequent, but for the rest, there were no significant relationships observed. Now for varenicline, it was available a few years before NRT in Australia, so we managed to get a larger sample of varenicline users. So we had just over 1,000 women using varenicline in pregnancy, matched to 10,000 untreated smokers. And the results here are quite interesting. There's a significant relationship between varenicline exposure and the primary outcome, so the summary of all adverse birth outcomes, with the risk of any adverse outcome being reduced among varenicline users compared to untreated smokers. And the same protective effect was apparent for 4 of the secondary outcomes. So that was for preterm birth, small for gestational age, severe neonatal morbidities, and low APGAR score. And for the other outcomes measured, we found no evidence that varenicline increases or decreases their risk. So these findings for varenicline suggest that not only does it not cause harm in terms of these adverse birth outcomes, but it might actually reduce the risk of some harms, probably via the protective effect of smoking cessation. But this is the first time that such a finding has been documented, and you might recall I mentioned earlier that there'd been one prior study of varenicline safety during pregnancy based on Danish and Swedish data. And this study, it had 335 women using varenicline, so it had less statistical power than our study, but it did show results in the same direction, but they weren't significant. So it would be helpful to replicate this analysis to determine whether varenicline is indeed protective against these adverse birth outcomes. But it's also important to consider that there's other possible harms that might arise from medicine exposure during pregnancy. And as I mentioned, birth defects are one that we've considered, an important one, with those results here. So because congenital anomalies are a rare outcome, we had limited capacity to look at it in this study. And the other problematic factor was that we only included women who were exposed during the first trimester to the pharmacotherapy, because this is when the fetus is most vulnerable to malformations. So this meant it was only possible to look at the risk of malformations for infants born to women using varenicline. And even within our varenicline group, many of the categories of malformations had we had very little data for. So, ideally we would have measured the risk of specific anomalies, because even malformations in the same body system have different etiologies, but we just didn't have the sample size for this. But what we could observe is that when looking at major malformations overall, and anomalies for the genitourinary and cardiovascular systems, there was no increased risk among fetus exposed to varenicline. But as you can see, the confidence intervals are quite wide, so we can't rule out a small or moderate increased risk. Okay, so I know I've covered a lot, so I'll briefly summarise the findings of this research, and then we can talk about what it all means. So in terms of utilisation, we found that bupropion use during pregnancy is rare, and varenicline and prescription NRT patches are used by less than 2% of pregnant women who smoke. Our investigation of the effectiveness of varenicline and NRT patches during pregnancy found that varenicline was associated with a higher rate of smoking cessation than NRT patches. And then our safety study found that none of the pharmacotherapies were associated with an increased risk of adverse birth outcomes, and that the risk of some adverse birth outcomes was reduced among varenicline users. Of course, there are study limitations to bear in mind when considering the implications of these results. So first is the limited number of pregnant women exposed to these pharmacotherapies. So that prevented us from examining all of the adverse outcomes that we had in mind, and it affected the precision of our effect estimates. This was most problematic when examining the risk of congenital anomalies. So we weren't able to examine the risk of anomalies among babies exposed to bupropion or NRT during gestation, and for varenicline we could only look at anomalies in broad categories. So the study can't tell us anything about the risk of specific congenital anomalies. Second, we only had data for pregnancies that result in birth, so not those that result in miscarriage or termination. So this means that there's potentially some selection bias in the study where it's possible that pregnancies exposed to these pharmacotherapies are more likely to result in early loss or termination, perhaps due to early signs of congenital anomalies. Third is that we examined the outcomes of prescription NRT patches only, where both patches and other forms of NRT were available over the counter during the study period. So this means that some of the pregnancies that we classified as unexposed would actually be exposed to NRT purchased over the counter, and this could have biased our results towards a null finding. And then finally, that dispensing data don't provide information about the actual use of these medicines, and it can't be determined whether women in our study use these medicines and for how long. So particularly for varenicline, given that its use is not recommended during pregnancy, there could have been more non-use of treatment among varenicline users, which means we would have underestimated its effects in terms of effectiveness and safety. So with those limitations in mind, we can think about the implications of these findings. I think first, it's encouraging that none of these pharmacotherapies were found to increase the risk of adverse birth outcomes. So that could be reassuring to women who smoke during pregnancy and their healthcare providers. But it's really important to note that the evidence is still missing for key outcomes like congenital anomalies and early pregnancy loss. So we're not yet in a position to make a claim about the safety of these pharmacotherapies in terms of the whole range of potential risks. Obtaining evidence on the remaining outcomes like specific congenital anomalies will probably require a multinational study so that we could obtain large enough numbers of women using these pharmacotherapies during pregnancy. And once we have evidence on the whole range of potential risks, our finding regarding the effectiveness of these medicines will be useful for informing decisions about which of these pharmacotherapies is most likely to benefit pregnant women who are trying to quit. So we found a higher smoking cessation rate among varenicline users than NRT patch users, and we also found that varenicline was protective against some adverse birth outcomes, presumably due to the effect of smoking cessation. So this would suggest that if we find varenicline to be safe, it might be the preferred choice for pregnant women because of the benefits it offers. Following from this, clinical guidelines might then be revised because they currently support the use of NRT during pregnancy, but not the use of varenicline. And I should just note here that we weren't able to examine the effects of combination NRT because it's not currently subsidised by the PBS. And as combination NRT is emerging as having similar effectiveness to varenicline in the non-pregnant population, this might be another treatment pathway worth examining in pregnancy, both in terms of safety and effectiveness. Just before finishing up, I'd like to acknowledge the government health departments listed here for providing data for the study, the 3 linkage units involved, and the funding sources. And finally, just to let you know where you could find more detail about each of these studies. So there's 2 manuscripts there that have been published, and the effectiveness work is still under review, but there is a conference abstract that has the key findings. So thanks for your time. I welcome your feedback and questions.
Thanks, Alice. That's a fascinating presentation. I can see we've got about 20 people online, and people can either write a question or probably easier just to unmute and ask a question of Alice. I guess while we're waiting, Alice, I wondered a couple of things. Do we have, from other sources, any indication of how often women actually use medicines like varenicline, you know, in pregnancy, in terms of, you know, reports of actual use? I take your point that you can only talk about dispensing over the time when you know, the prenatal data shows that they were pregnant. but it'd be fascinating to know how many women were actually taking the medicine.
Yeah, no, I'm not aware of any data on that, but I think it's quite interesting. Like, if we think about varenicline in particular, you know, seeing that it was associated with reduced risk of some of the birth outcomes, it does suggest that probably it has been used, you know, to be able to exert that kind of effect. Presumably, it's either being used during pregnancy or it has been used prior to pregnancy and been successful.
Yeah, that's a good point, because otherwise you would have thought there would be no effect on smoking rates, when there does seem to be.
Yeah, exactly.
Yes,
Yeah.
it is being used, but you know,
Yeah.
mission, you know, probably, you know, maybe the women aren't telling their whoever's looking after the pregnancy about this. Otherwise, they might be told, please stop using it. So that's an interesting one as well. You know, how often, you know, are people actually having a discussion with the clinician? And maybe it's good that they're not.
Yeah. Yeah, we would like to follow this research up. You know, I think I mentioned that probably the next step would be a multinational study, and I think if we had enough women exposed, we could do some sensitivity analyses where we restrict it to women that weren't dispensed the medicine until quite far into the pregnancy. You know, so you'd assume by that point they would be aware that they're pregnant and that they're consciously choosing to take it.
There's a question from Claudia Bruno. Have you got any estimates of private prescriptions and the over-the-counter medicines? I guess Claudia's asking, what do we know about the extent of over-the-counter use? That would go particularly for NRT.
Yeah, unfortunately not, especially during pregnancy. You know, you can get sales data on NRT through pharmacies and supermarkets, but you don't know who it's sold to. But there is quite a price differential. So buying NRT over the counter is, you know, for a course, I think it's in the hundreds of dollars, whereas, you know, through the PBS, you'd pay $40 for a dispensing. So I think there is a motivation to get to use the subsidised version. But what I think is a bigger concern is the programs that offer free NRT. I mean, it's obviously, it's great, but I mean, for our research, the concern is that we're not identifying completely free NRT because, you know, the motivation, the cost motivation is not there for those supplies.
There's a question from Linda Lee Wilkie in the chat. Are clinicians on the webinar using varenicline in pregnancy? Oh, that's an interesting question.
Yeah, I'd like to know the answer to that.
Well, this particular clinician in myself is not. I think again after today, but I haven't been. I guess, you know, I comment as someone who chairs a guidelines group. One of the things that we often do, you know, and need to do in a guideline group is a meta-analysis of randomised trials of medicine. And, you know, so that in the absence of randomised trials of varenicline in pregnancy that measure effectiveness and safety, I think it'd be pretty hard to see them get into a guideline recommendation in the way that guidelines, you know, tend to work at the moment, where you have that level of evidence of both effectiveness and safety. And, you know, I totally agree that the extent of evidence on NRT in pregnancy is not wonderful. But at least there are RCTs which show some degree of benefit and which have looked at safety outcomes. And so I guess one of the things that I think out of this is, well, how on earth would a study be, funded, and maybe it'd have to be an international study to look at varenicline in pregnancy, both against placebo, I guess, or usual care, and perhaps against NRT as well, to see if it is really more effective.
Yeah, I mean, I guess that's the likely next step with observational research, because there are concerns about confounding that maybe it's just enough evidence to show that there aren't major safety concerns, and that's enough to make doing an RCT more ethical and just acceptable.
So I see Moya Mani has said she's not using varenicline, or her service is not.
Right.
So Moya's also asked, do you consider the use of both NRT patches and varenicline together during pregnancy? Well, that's an interesting one.
I don't think we would have enough of that in the data, because the PBS restrictions around these medicines is that you're on one of these pharmacotherapies only. So that wouldn't be something. I suppose in the data you might find the odd case where it's sort of slipped through and both are being dispensed, but I don't think we would have enough cases of that to do any analyses on. And I guess the other possibility is that someone is dispensed varenicline through a PBS script, and they purchase or get for free NRT over the counter or through some other program, but we can't identify that.
Yeah, well, as you would know, Alice, there's some evidence that combination of varenicline with nicotine patch may be more effective than varenicline alone. And we actually did make a recommendation around that in the College of GPs guideline to say that that is worth considering. Most trial evidence to show increased effectiveness over varenicline alone. Not a lot of studies, but a small number of studies.
Yeah. I mean, it'd be great to be able to look at that, but we're constrained by, what the PBS allows, and then what that means appears in the data.
And I guess you didn't have enough data to look specifically at Aboriginal people, or, through the Close the Gap, PBS, Yeah,
that's right, we didn't. And I suppose, with the goal that the next step would be a multinational study, it's probably not going to get addressed there either. It's Australian data. Well, I suppose you could do a sub-study on the Australian data alone, because this study was based on data up until 2012. If we were to do it again now, having an extra 8 years of data would really increase the number of exposed pregnancies. So I guess there's potential there.
As you know, there's been quite a lot of discussion about increased metabolism of nicotine during pregnancy, and whether one of the reasons why NRT is not proved wonderfully effective is it's underdosed. You've alluded to that in sort of combination NRT, but that is another issue here is whether pregnant women are underdosed with nicotine at standard, the standard sort of recommendations.
That would be. I mean, would you, as a clinician, would you prescribe combination NRT to someone who was pregnant?
As a personal view, I think there's not reason not to. We know from non-pregnant populations that there's no increase in adverse effects of combination NRT over monodosing with NRT, and I can't see why that wouldn't be the case in pregnant women. There isn't a lot of data that I'm aware of that helps there, but we also do know that stopping smoking is wonderfully good for pregnancy and outcomes, both for the mother and the infant. So in the context of that, you know, that becomes a discussion around benefits versus possible risk, fairly known benefits versus not terribly well known, but almost much lower risks.
Yeah. Yeah. And I suppose that would be through, like, you could prescribe the patch or actually or a gum or lozenge through the PBS and then recommend the patient purchase the other over the counter.
Yes, that's how combination NRT happens now, because, as you know, combination is not subsidised on the PBS, despite some lobbying that it should be. Yeah, so that's what currently has to happen.
Yeah. Okay.
One of the other questions, I guess, has come up and more applies to NRT is, you know, there's been animal studies that suggested that there may be risks of exposure to nicotine during development on neurodevelopment, particularly perhaps if it's continuous exposure rather than intermittent exposure. I don't think there's been any human data to support that. But does that suggest that maybe you need longer term, you know, I know these are rare, and it's, you know, to follow those infants to look at their cognitive or their neurodevelopment over time?
Absolutely. Yeah, I mean, that's, you know, that's a risk associated with smoking during pregnancy anyway. So there's potential that these pharmacotherapies could either assist with that by promoting smoking cessation and potentially improving neurodevelopment in the child, or that, you know, and that NRT itself, or actually any of the pharmacotherapies could have adverse effects on neurodevelopment.
Yeah. Okay. Are there other questions from the group? Watching the Q&A and the chat lines, I haven't seen any further on either.
Well, my email address is there. If anyone has any interest in following up or asking any further questions, I'd be very happy to talk. Thanks,
Alice, and certainly very interesting research and a prompt for, I mean, further research in pregnancy. It's so hard to get that work done, isn't it? Because of all of the barriers to doing medicine's use in pregnancy, and goes with young children as well. So we often have a fairly data-free zone when people are trying to decide what as a clinicians, what's the best thing to do. And I know many people on this call would work in contexts of health department, you know, state government funded services that have quite strict protocols. So have ability to make use of medicines when the protocols don't support them is quite limited or constrained, and that may be a factor as well. So I doubt that we're going to see a lot of increased varenicline use unless those RCTs are done. Anyway. Okay, thanks so much, Alice, and thanks, Liz, for organising everything. Thanks everyone who's attended. You've got an extra 10 minutes in your day you didn't know you had. So
thanks everyone for your attention and interest.
Okay, see you.
Okay, bye-bye.
Bye.